This is video number 1 of End of Life Issues. I want to start by saying that I think becoming a professional in end of life care is probably the most noble and wonderful thing a nurse can do. I have attended many, many births and I have attended many, many deaths. And I have to tell you that I think that being at a death is far more miraculous. And I am always honored when I am part of that process. As LPNs, especially if you work in long-term care, you will be dealing with end-of-life issues a lot. Unfortunately, we give you a little taste of end-of-life care and a few noble lessons, but it is a specialty all its own, and I can't do it justice, but I'm going to try. Of all the patients who die, less than 10% die suddenly. Most people die after a long period of illness with gradual deterioration until an active dying phase at the end. At the very end of life, there's no second chance to get it right. Therefore, the end of life choices are very important. And I say all that because I think it's important that every person, no matter how young or how old, has a plan for what they want to happen at the end of their life. Young people die too, and young people with children die too. And it's very important that a plan is made for what you want to happen. As a nurse, it's our job to be clinically competent, willing to educate the patient, be calm and empathetic. All of this reassures and is so critical to helping the patients and their families in the last hours of living. Care does not end until the family has been supported with their grief. That is really important. We think the body dies, we want the family to leave, and we want to fill the bed. That's what you see in the hospital setting all the time. That is absolutely unacceptable. That family should be able to stay with their loved one as long as they want. The body is not going to hurt anyone. It's not going to start to decompose within a few hours, especially in appropriately heated and air-conditioned facilities. We need to make sure that we do not rush the family. We have to get them the appropriate grief support that they need. And if it's complicated, and I'm going to give you a little hint, the more dysfunctional the family, the more complicated the grief. The more functional the family, the less complicated the grief. I don't know if there's research on that. I can just tell you from my own personal experience. Every patient has the right to refuse treatment. So you get to the end of life and you don't want chemotherapy anymore. You have a right not to take it. You have a right not to accept fluids when you're dehydrated. You have a right not to accept antibiotics when you have an infection, and you have a right to not accept care and to die peacefully. We all have that right. We have a right to uphold our religious convictions when we're dying. So if life-saving treatment like a blood transfusion would help us, we have a right to refuse that if it's against our religion. There are many, many levels of care at the end of life, and the patient needs to be educated. And all patients need to be educated and encouraged to learn about the end of life and to make a plan. People who are afraid to die want you to do everything. They want CPR, they want drugs, they want everything. That's because they've seen CPR on television, and they've seen flatline patients coded, and they shock them once and then they come back and they're perfectly fine. That's not the case. When CPR is performed, 9 out of 10 times ribs are broken. The sternum might be cracked. The pain is horrific when they recover. They're usually thankful that they do. But when someone's 85 years old and on the second compression you crack their ribs, you really do have to question if it was the appropriate thing to do. Again, it's all about patients' rights and how they want to live out the end of their life. Do not resuscitate. This is a big deal, and especially with you who will be working in nursing homes, you have to have these kind of orders. They are written in a hospital or a nursing home. They're done in collaboration with the client and the family. If they are do not resuscitate or no code, that means no CPR will be given should the person cease to breathe or the heart stop. They can still have aggressive treatment up to CPR, in other words, antibiotics, breathing treatments, BiPAP, CPAP, anything like that. A durable DNR is an out-of-the-hospital DNR. In the state of Pennsylvania, we call that a POLST, and it's Pennsylvania Orders for Life-Sustaining Treatment. These are amazing because they follow the patient. Up until just a few years ago, if you lived in a nursing home and you had a DNR, and then you went to the hospital, your DNR was not in effect until you had a new order written and your family and you signed it. Well, most nursing home patients that are DNRs come to the hospital because they might need to use that DNR. So it was a very bad thing. So they created this form called the POLST, and the family and the patient, if they're able, work together to fill out this form. And it says, what do you want? Do you want CPR? Do you want CPR and medications? Do you want CPR medications and artificial ventilation? Do you want CPR medications, artificial ventilation, and tube feeding? And it goes on and on. Do you want antibiotics? Do you want this? Do you want that? And that travels with the patient. It's a bright pink form. It goes with them in the ambulance. It comes back with them with their discharge instructions. And it's really pretty awesome because it really does define the wishes of the patient. So advocate for your patients to have a POLST. Feel free to look that up, POLST, Pennsylvania Orders for Life-Sustaining Treatment. Advanced directives. POLST is like a little advanced directive, sort of. Advanced directive is a written form that lets the person making it, which is either the patient or their power of attorney, durable power of attorney, lets their wishes be known. In class, we're going to do, I'm going to show you a sample of an advanced directive that I like. It's called the 5 Wishes. In the meantime, feel free to get on the5wishes.com and read about advanced directives. It requires, depends on the state where you live, but an advanced directive in a hospital requires 2 witnesses. This says not family or healthcare providers. I don't believe that to be true. I've witnessed many advanced directives, but we have social workers and all kinds of stuff, people that do that. The 5 Wishes is an advanced directive that the patient does independently. It's not connected to the facility. You can do them now. I'm going to give you a sample, and basically it asks if this happens. If you have, a traumatic brain injury, what do you want? If you cease to breathe, what do you want? If you have this, what do you want? And it is a very comprehensive form, and it has to be notarized, the original put in your safe or something, and then you can make another copy that's portable that can go with you or your loved one to the hospital. And again, I'll explain all of that in class. A living will, people connect advanced directives and living wills. They are really kind of different. A living will documents what the physician and the client's preferences when the client is unable to communicate, found dead, declared terminal. Some states have different standards regarding living wills, and advanced directives are more comprehensive than a living will. Here are some links: advanced directive for healthcare, a living will, sample forms for advanced directives. All of those, if you have an interest in this kind of care, they're very good. Durable power of attorney. Important for you to know. It's the person who will make the healthcare decisions for the client when he or she is unable. It's needed for all of those areas that are not addressed specifically in a living will. Many people confuse this with a regular power of attorney, which allows you to handle their finances. But a durable power of attorney is completely different than a power of attorney. Here are some choices on advanced directives. Do you want to be a DNR, artificial feeding or hydration, antibiotics, artificial respirations, dialysis, hospitalization, surgery, chemotherapy, radiation therapy? What kind of treatments do you want depending on what's going on with you? It's much better to, for all of you young students who have living parents, it is really good for you to find this out now while your parents are young and healthy, because when someone's ill, they can't make good decisions, and they can't make decisions that they might have made if they weren't up against a wall. Palliative care is different than hospice care. Palliative care manages symptoms with no chance for a cure. So they manage pain, fatigue, cough, fever, anything that makes the patient uncomfortable, and palliative care provides emotional care and grief support. Palliative care is kind of that line between curative care and end-of-life care. People can live, if their symptoms are managed, for a really long time, depending on the illness. So there is a difference between end-of-life care and curative care when you talk about palliative care. Here are some case studies, and we are not going to do that now, obviously, because we're not together, but we will do that in class if we have time. Process of dying. People are going to ask you all kinds of questions about dying. How long does it take to die? There's no answer for that. However, there are signs and symptoms that someone is dying. And those are actually pretty obvious. And then you can plan and implement care depending on how close they are to dying. One of the most important things about being able to recognize when someone's at the end of life is letting their family know that if they want to be there, that they need to get there. If they have anything to say, they need to say it. And you can tell. One of the biggest concerns when someone is dying, both for the patient and the family, is to keep them out of pain. The patient can't maintain control if they're in pain. They can't breathe appropriately. They can't make any decisions or communicate, even if they were able to. So we want to make sure that we handle their pain, and if they are alert, that we don't manage over sedate them where they can't then communicate with their family. Fatigue and sleepiness, not necessarily a sign of impending death, but almost everyone at the end of their life is sleepy. Again, this interferes with tasks they might want to complete. If we can help them by providing rest and then alert time, that will make their time with their family better. Near the end of life, the patient will sleep and you won't be able to arouse them. The heart changes. The peripheral circulation will diminish, so the hands and feet will start to turn purple. Extremities will become cold, cyanotic. Peripheral pulses may be difficult to palpate. Blood pressure will decrease. Body temperature may go up. It also may go down. Depends on what's going on with the patient. And again, you want to keep this patient comfortable, warm, sedated as necessary. Medication, to keep them adequately breathing. Probably one of the biggest things that you see at the end of death is respiratory changes. You'll hear terms like Cheyne-Stokes breathing, agonal respirations. I'm trying to remember what the other name for it is. Sorry, it just slipped my mind. But there is a very distinctive way a patient breathes at the end of their life. And Kussmaul's respirations, that's the name I was looking for. It's very distinctive. It's kind of hoarse, loud, and their respirations will go from normal to 10 to 7 to 4. per minute, and then they'll become very agonal and just there'll be an occasional breath until finally there are no more. Gastro changes. At the end of life, people don't eat